Today we're going to show you a case in which there is going to be a broken posterior synechiae after an acute attack of anterior uveitis. We're going to show you what it looks like once the synechiae is broken, and then we'll take you back to the first picture of the patient in which there was the attack of acute anterior uveitis. Before we start off, let me just show you what we're seeing over here. So if you look at the patient, this is a slightly broad beam examination of the anterior segment and the cornea, and here you can see this whitish area. This is the area where you had posterior synechiae formation 360-degree around the pupil, and because of the dilating action of the mydriatrics, the pupil has dilated and has broken off from the posterior synechiae. That is why it's so important to break those synechiae immediately. Otherwise, you can have a total 360 synechiae formation of Secluso pupillae, and that will lead to the formation of iris bombae. Because if you do not control this, and if the iris gets stuck over here and it produces that iris bombae because the pupil aqueous cannot go forward. And what you see over here, this is a small bit of hypopion which is left after resolution of this patient with anterior uveitis. Let's clear this and let's go forward and see the other parts of the examination. So whenever you're doing an examination of the slit lamp, you probably, this is just for making a video, you wouldn't start off with a diffuse examination. You would start off with a slit lamp examination. You can see the amount of ciliary congestion you're seeing over here is just very faint hue at the moment. But after this, when I show you the video in which you saw the acute inflammation, you will find out what it was. Now, when you go in to examine the anterior chamber for cells, you need to put the light on the side of the pupil and need to shine it and then go on to higher magnification to see cells. Sometime on videos it's difficult to see the cells, but I'll just stop when I show you the flare. So I've reduced the size of the slit so you can see over here, and then once that slit is being reduced in size, you're able to see that flare much more easily in these patients. And the cells are differentiated, and you will also see keratic precipitates in these patients which are present in this area of the cornea. So here, now this is the area where you can easily see that nice flare over here. So this is a flare which is, you can see that beam of light, and you see cells over in this area. So you can see the best place to see the flare is when this light shines over on the edge of the pupil and you see this flare over in the center where the lens is. So you see that thing in the darker area of the lens because light is shining obliquely. You are not getting any red reflex in these patients. So you need to have it in a higher magnification, and you need to make the slits smaller to just look at those flare and cells. Because initially when the patient came in, he actually had more than flare. He had the highest grade of flare, which was the formation of fibrin, in which you could see suspended cells in the anterior chamber. So this patient was already, so you want to look at the posterior segment to see, you can see the disc over here. This patient had just anterior uveitis. If you are not able to see the disc, that would tell you the patient has a lot of intermediate uveitis. So here is the synechiae which has been broken in this patient. And let me just pause this video for a second. So now you can see this is the same patient in which he initially presented a week before with this severe uveitis in which you were seeing fibrin, you were seeing hypopion, and there were suspended cells in the hypopion. And you can see even the hypopion is not settling down in gravity, is giving that peaked appearance in the center. So you want to treat these patients with intensive steroids, subconjunctival steroids, which would include dilating drops as well, which would include midricaine, which would have atropine and epinephrine or adrenaline in that. And you would go in and dilate the pupil later on with atropine eye drops, use topical 1 hourly drops. So the basic principle in severe uveitis is hit the uveitis hard with strongest medication, steroids, and then slowly taper them down once the inflammation has settled down. If it's very severe, then and it's not responding to treatment, then you can go on to intravenous or oral steroids as well. So the main cause for pain in these patients is the ciliary spasm, and that needs to be relieved. And the main cause of blurring of vision is because of that fibrin and the cells in the anterior chamber which you see. Thank you very much for watching.